Hello and welcome to Your Health DeKoded. Are you tired of health advice that feels impossible to follow? Each week, we're going to bring you practical, realistic guidance for a healthier life. There'll be no preaching, no fad diets, no unattainable plans. Instead, we'll connect you to credible medical experts every week who will break down complex health topics into straightforward information you can actually use. They'll explain what conditions really mean and offer reasonable approaches to managing them. This week, weight loss and the Mounjaro phenomena. Everybody in India is talking about Mounjaro, the new injectable medication for adults with type 2 diabetes that's making waves after Ozempic's popularity. But what's the real story? I have with me two incredible doctors, Dr. Shashank Joshi, an endocrinologist and a diabetologist, and a Padma Shri awardee. Thank you so much for being with us. Dr. Joshi was also part of the COVID-19 task force for the state of Maharashtra. I also have with me Dr. Himika Chawla, a senior consultant in endocrinology and in diabetes. Thank you again so much, both of you, for joining us. So I wanted to begin by asking you why are all diabetic medications being taken over for weight loss? Dr. Joshi, if I can start with you.
First of all, congratulations to you and your entire team for doing the health educational piece. And you're very right that many medications related to diabetes are now being explored for obesity. This is a gut peptide called incretin, called a GLP-1, GIP. These are basically nothing but small little protein blocks which our intestine makes to regulate glucose. But they also switch off the appetite in the brain and they burn some fat. And that is why they definitely cause weight loss, which is credible. It's scientifically experimented and FDA approved and even Indian DCGI approved. So this is slowly becoming a standard of care. Because as you know rightly, that there has been a dubious distinction of every anti-obesity drug which came on planet Earth, unfortunately got banned because of adverse events. And I think the diabetes root medications appear to have a larger safety valve from that standpoint. And that is why probably this GLP-1 backbone, which is the glucagon-like peptide. Glucagon is opposite of insulin, which makes you gain weight. Glucagon actually protects you from hypoglycemia. So these are cut peptides of glucagon secreted by some cells in our intestine and the GIP. And these molecules now are revolutionary in some way and are highly evidence-based, and they have some compelling indications. And weight loss is right on the pecking order.
Dr. Himika, when you treat patients with diabetes, is there currently an overwhelming desire to sort of go away from planned medication, diets, and instead just jump to these shortcuts? Are you seeing that trend?
Yes, partly because we know that obesity is what starts this entire process of metabolic syndrome. So obesity is particularly important in the causation of diabetes. And yes, we do want our patients to lose weight, because losing weight, even 5 to 10%, produces remarkable improvements in the blood glucose control of patients. Blood glucose reduction, even going to the tune of remission can happen with a weight loss of more than 15%. So yes, hearing all this data, and also as doctors, we are also excited about the weight loss thing, and particularly because we know that 10 to 15% of body weight loss can induce some temporary remission. Of course, diabetes is a progressive disease, so some amount of progression will happen, and it's unlikely that the patient will remain off medications completely for a longer period of time. But yes, this is primarily the inclination why people are sort of trying to jump to drugs like these for they consider it to be a shortcut to this diabetes, a quick control of diabetes, and maybe inducing remission in some patients. But obviously that's not the right approach, and these drugs are good, and they produce a weight loss also, and of course they are primarily designed for the management of type 2 diabetes patients, but the patients have to be carefully selected for who can be given these drugs.
When you say that patients have to be carefully selected, would you just elaborate on that a little?
Yeah, of course. We do see that most of the patients with type 2 diabetes in the Indian context are also overweight or obese. But of course, that has to be seen. When the patient with type 2 diabetes comes to us, we have to assess what state the patient is in. Now, if a patient comes to us with really high blood glucose values, he is rapidly losing weight already, he's in a catabolic state, he may be also having some evidence of ketoacidosis in severe cases of diabetes. Now, these are not the patients where we will give drugs like these. And of course, the decision to start a GLP-1 receptor analog, or be it Mounjaro, which is the GLP, and the GIP agonist, is that these patients should be towards type 2 diabetes, and they should be preferably we would try to give it in patients who are overweight or obese, not the leaner patients. Then there are certain contraindications which we also have to keep in mind, like a history of pancreatitis or a history of a medullary thyroid cancer, where these drugs are not to be given. Of course, the patient selection is important, and ruling out the contraindications is important. And we'll also elaborate on the gastric side effects that these drugs could have. So that is also important. If the patient doesn't have too many pre-existing gastric issues, that patient may not be a very good candidate for this drug.
Dr. Joshi, apart from diabetes, what one is also seeing is that a lot of people who just want to lose weight, they don't have diabetes, they want to use these medications. Now, how does one counter that?
So, legally and officially, these drugs are now approved for weight loss. As Himika ji rightly said, that 5 to 10% loss is what they give. So, clearly, whether it is the semaglutide or the tirzepatide, which is a single agent or agent, they will cause weight loss anywhere between 5% to 15%, and based on the selection. But they have to be carefully supervised under medical supervision. These are over-the-counter drugs. There are contraindications, as she rightly said, of disease of the pancreas or gallbladder or any condition, and they have to be started with a very small dose and go slow, and then gradually titrate it. So they are a part of it. But obesity is a disease. Obesity is not some, and we are thin fat Indians. So compared to rest of the world like Caucasians or Africans, we tend to store more fat in our body composition. So fat loss is as important from ectopic sites like the liver or the epicardial adipose tissue as is the weight loss. So these drugs definitely not only cause weight loss, but they also cause fat loss, and they have some compelling indications. Like for example, somebody snoring with sleep apnea and they're needing a CPAP machine, or if they are having a metabolically associated fatty liver disease, or as it is called as MFLD, then even that ectopic liver fat or the sleep apnea, that can also be resolved. So clearly we see that medications in obesity have a space. Obesity is the mother of all diseases, whether it's mental health issues, medical issues, various issues related to mechanical complications, and therefore treating the underlying cause and chopping off the fat. And we are, also we saw the pitch at the Fit India and the Khel Games, Honorable Prime Minister also talking about obesity, reducing fat by 10% and edible oils by 10%. So it's important to recognize that it's a compendium. These drugs are useful, but they have to be done in conjunction with lifestyle. They need a mental health screening. They need a onco screening, as Dr. rightly said, and they need, if appropriately indicated, weight loss and fat loss will give us medical benefits and health benefits. And also overall, they make you, because, remember, extra fat or obesity also has a lot of stigma and image related issues, and therefore people when they lose weight, they tend to be happier also. So overall, I think from a health quotient standpoint, there are compelling indications for it.
So it's very interesting that you say we're thin fat Indians. That's such an interesting term. I think all Indians will want to be thin Indians. But tell me, apart from those who obviously have conditions, either there's diabetes or they're obese and that's medically a problem, now there is a trend that is seen in youngsters who just want to lose weight, and they are going this route of Ozempic or Mounjaro without sort of looking at the side effects that you're talking about. How does one counter that? And you did refer to body shaming or image issues. So should that not be countered with better planned diets or exercise, and not with these quick easy drugs?
So this needs medical supervision or endocrine supervision. You're very right. And it needs a plan. So the plan needs to include a lifestyle program of physical activity, behavioral modification, diet plan, a medication, sometimes even an endoscopy or surgery based on the various type of degree of obesity. So I agree with you totally that one should not be rushing just like a fashion, that I'm on a XYZ drug and there should not be any FOMO on this, or that type of a feeling in the young people. They need to be mindful. They need medical supervision, and they need to be ensuring that all this is done under medical supervision, so that there is no ulterior or unfortunate adverse events which occur. So remember that it's important to lose weight, and it has to be integrated part of a comprehensive weight management program, which includes lifestyle and some other measures as well.
Dr. Chawla, tell me, for instance, in India, medical insurance is a huge deal. Now, are these drugs part of sort of the insurance packages that people come with? Is this something that the medical industry is considering? What is that scenario? Because there's been a lot of talk about how pricey these drugs are.
Yeah, the drugs are definitely pricey, but in India, conventionally, it is definitely covered in the insurance plans in the West. So this drug, as sir mentioned, it is not only for obese patients, it is for particularly for diabetic patients who are obese. And if we treat the diabetes along with the obesity, we do get benefits beyond just the blood glucose control. We get a better cardiometabolic profile. We better get lesser number of cardiovascular events and the mechanical complications and the psychological issues that arise out of obesity. So yes, it's covered in the West, but in India, as we know that most of the insurance cover that we get is during the hospitalization. So these drugs have to be given long term. It's not like a 2 weeks or a 4 weeks or a month's therapy. They need to be given lifelong, also in certain patients. But yes, even if we don't say lifelong, we do say it's going to be a little long-term exposure, maybe a couple of years or maybe a year plus or so. So definitely these patients have to be prescribed these drugs on an outpatient basis. They are also getting covered under the various health schemes that the patients may be having, like central government health services or other, company related health schemes that they may be beneficiary of, but again, not as a part of the insurance covered. It should be covered under the different health schemes or beneficiary that they may be part of. Not all the drugs. Currently, Mounjaro has just hit the market, so the indications are particularly in diabetes and also in patients with obesity without diabetes. But the coverage is not like you're not going to get for all the patients who are admitted, because it's a long-term therapy. It has to be continued on an outpatient basis.
So, but currently, then it means that only very few in India will be able to afford these drugs. Compared to, let's say, normal diabetes medication versus Ozempic or Mounjaro. I mean, that's not a viable option for an average middle class family, right?
True, because the indications are very wide for this. Sir has already outlined on many of these indications. So yes, considering the cost factor, this I think is the most important factor why we may not be able to give it to lot many of the patients who may actually benefit from this drug. So I think the cost is, of course, the biggest hindrance that may be there in the utilization of the drugs, and the patients who actually need it might not get it.
I also wanted to ask you, Mounjaro versus Ozempic. You're two experts. What would you recommend?
The Mounjaro and Ozempic are different in the way that Ozempic is particularly an agonist of the GLP-1 receptor, and Mounjaro is an agonist of the GLP-1 receptor as well as the GIP peptide. So it has a dual action. So that is why it also called as the twin incretin term is also given to it. So Mounjaro has a higher efficacy when we compare it to the action in terms of the weight losing capacity. So most of the trials have shown that Ozempic may produce a maximum weight loss of say more than 10% going up to 15% of body weight loss over a longer period of time, of course. While as Mounjaro, the highest weight loss could go up to more than 22 to 23% of body weight loss, and on average also the if you could reach to the higher doses of Mounjaro, you would usually get a more than 15% body weight loss in many of your patients, about 7 out of 10, at least 7 out of 10 of your patients. So when we talk about the absolute amount of weight loss, the efficacy of weight loss of Mounjaro is higher than Ozempic. When you talk about the cost is more or less similar as of now. Third thing, while as the Ozempic has not been officially launched in India, but it should be launched at a similar price that Mounjaro is. And thirdly, when you talk about the glycemic efficacy, that is more or less similar. So both of them would produce an HbA1c reduction of 2 to 2.5%. So yes, the weight loss is more with Mounjaro. The cost is almost similar, and we have to see what is the requirement in our patient. Why are we giving it just as a treatment for diabetes, or we are giving it as just for the purpose of weight loss, and the desired weight loss, if the desired weight loss is more than 20% or so, these patients would be a better candidate for Mounjaro.
Right. Dr. Joshi, these medicines, both Mounjaro and Ozempic, were developed in the West. Presumably, no trials were done on Indians. Indians have a different genetic makeup. Is there some concern that they may have some other side effects that have not been considered for Indians?
I think that's a great question. So I would just like to elaborate that in India, the Ozempic oral version Rybelsus has been available for last 3 years, and the injectable version, which is little better than Ozempic, called Wegovy, will be launched in another couple of months. That is a semaglutide backbone, and the Ozempic has not been launched in India, unlikely to be launched in India. The Mounjaro or the tirzepatide is available in India. So for both the semaglutide program and tirzepatide program, as a part of the global program, people from India living with obesity and people living with diabetes both were included. So there is some Indian data before the regulator approved. But you hit the nail. The nail is that we are thin fat Indians. Our obesity cluster of phenotype is different from the West, because you may look on BMI thin. Our BMI at 23, 24, we store much more fat compared to a Caucasian. And therefore, the data here on the lower doses needs to be systematically studied. And that is a need of the hour. And we are carefully looking at all this. We are all sworn by Hippocrates oath, primum non nocere, first of all, do no harm. So right now we need to be pharmacovigilant. But the global data on both these molecules, which includes Indian patients, including cardiovascular safety and other safety, including, like, for example, the SOUL trial done on oral Rybelsus, had Indian centers, which was where it was experimented upon. So we do have some Indian data on these molecules. But now that the molecule has been available, for example, oral Rybelsus for 3 years, and now Mounjaro will be available, now Wegovy will be available, we will be able to do pharmacovigilance. And nausea, vomiting remains to be on the top of the order. But the degree of fat loss and the degree of weight loss is likely to be more pronounced at a lower dose in the Indian population, is anecdotally an observation which I can tell you. But I think time will tell. But I fully buy your point that we need to be pharmacovigilant, and which is why an endocrine or a medical supervision is something which is necessary. And these are not over-the-counter pills to be taken, or medicines or injections to be taken by a FOMO phenomenon or Instagram phenomenon.
Right. So this is a question for both of you. You spoke about being vigilant. You spoke about that it's not an Instagram phenomena. If tomorrow an 18-year-old girl comes to you and she's just hell-bent, insistent on taking one of these medications. She does not have diabetes. She's not really obese. But in this day and age of social media, she feels pressured and she wants to lose weight. What is the way forward from there?
So I think the indications are pretty clear. So we do have our Indian guidelines for obesity also, in addition to the Western data. So we use BMI cutoffs, although it is not a wholesome marker of obesity. We must include waist circumference also. But even for an Indian patient, if the BMI is more than 32 without any comorbidities, then we can give drugs like these. And if the BMI is more than maybe even 27 as an Indian cutoff. For the Western, it's about 30. If we have comorbidities like diabetes or hypertension, dyslipidemias, or presence of coronary artery disease, or other OSA, so other comorbidities associated with obesity, we can treat patients with a BMI of more than 27. And if patients don't have any comorbidity, then the treatment is not to be utilized. For patients at least who have a BMI of less than 32, you must not utilize. And for the Western population, the cutoff is 35 kgs per meter square. So coming back to this girl, so if this girl satisfies the criteria for the BMI, so an actual obesity, or she has some comorbidities, we must consider. Otherwise, the right approach is to counsel the patient, put her on a right kind of diet and exercise, and motivate her to work on the lifestyle modification better to get the results on the weight loss. Definitely, these drugs do have side effects, particularly when given in patients where the indication is not there. So I would definitely not consider giving this drug to a person just based on the psychological thing.
Right. Okay, I also wanted to ask, our Indian diet is all puris and parathas and aloo ka sabzi and like it's a fatty diet. Now, we take Mounjaro or Ozempic on one side and then we go back home and sort of have all our fried ghee stuff. How does that work?
Basically, these drugs switch off the appetite and make you eat less. So you will basically that's how they work. So you tend to eat much less of food, and that is why the food industry is very concerned when these drugs got launched worldwide. And if you see their projections after 5 years and 10 years and 15 years, they realize that people will consume less food. That's the precise mechanism how they work and they play upon. And we as Indians tend to eat fast, tend to eat more, tend to eat like extra, and we definitely need to modulate that. But I think one part that we need to eat slowly, we need to eat on time, we need to eat less, we need to have some proteins. So even when you're taking these drugs, we will lose whenever you lose weight, you also lose muscle mass, and suddenly you might become frail and you may feel little aged out. So it's important that it is medically supervised. You need muscle strengthening exercises. You need to maintain your muscle mass and bone health. And you also need to ensure that micronutrients are supplemented and some protein supplements are coordinated, which is why there is a compelling need for a proper medically supervised obesity program for that individual. And therefore, it is important to recognize that obesity, being a medical disease, needs medical management under supervision, and it is not something to be done anecdotally over the counter. So that's something which is very crucial. And I agree that Indians tend to eat more and walk less. We have become very sedentary, and we also are, we love to generate stress. We take stress and give stress, and all this is important. So outcomes are not just health outcomes, happiness outcomes are as important. And I think these medications have evidence to show that not only the health outcomes and heart outcomes and other outcomes improve, but also the overall mental well-being also improves. So it's important that this has to be a team approach. We need a lifestyle coach with some dietary advice, some muscle strengthening exercises, a behavioral, or a mind coach, and eventually we need to ensure that people take it properly without any adverse events and feel good and happy about it. But eventually they can make a change in their lifestyle so that they stay a little lower on their BMI and stay healthier.
Right. So, is there going to be a push from the medical community on ensuring that these are never over-the-counter drugs?
I think there is a push from the medical community that these are anyway prescription drugs, only to be given by endocrinologists or internists or physicians. And even the Drug Control General has very clearly advised that these are drugs to be given under medical supervision.
That's it this week for Your Health Decoded. Join us again for another episode. But to all those youngsters out there, stay with a good diet, exercise. Don't really look at these short-term drugs. Well, not short-term, long-term, but these shortcut drugs. Because as the doctor said, they are for certain medical conditions. Thank you, Dr. Joshi. Thank you, Dr. Himika. That's it for this week. Join us again next week for Your Health Decoded.